Nasir, can you unmute yourself?
Yes, sorry, Dr. Junaid. I cannot share the content from my end because it's saying that only host can share this meeting.
Faraz, can you give make Dr. Nasir as a host? Nasir, now you can do it.
Okay, let me see that.
Co-host now, yeah.
Can you guys see the slides now?
Not yet.
Okay, hold on. iCloud Drive, Google Drive, Box.
This one, the green thing, the share screen thing.
Yeah, it is actually not a Microsoft SharePoint. So it is not letting me share my screen, but it's already open on my end. The screen is, I can see it on my end, but somehow it is not.
You are on Zoom or something else?
I'm on Zoom, and so, it is.
So this is green arrow, the share screen not there?
There is share content, but what it is saying is that it is not giving me an option to open up my screen. I cannot open my screen. It is giving me option for Photos, iCloud Drive, Dropbox, Microsoft OneDrive, but not my screen.
Nasir? Yes. Just click, open your presentation, click the share screen, and then click presentation. Open presentation. Just share screen, then it will show options available to share. Then it will show your opened PPT. Then you can click that.
We are now open PowerPoint. It's not letting me do that. Somehow share content, share iCloud Drive, Microsoft OneDrive.
It said share screen, not the share content.
So you can share your presentation with any of the participants, like panelists. So
you know what I can do? What I can do, Nasir, I have your presentation. If you want, I can share from my side.
Go ahead, you do it from your. You go ahead, from your side. I'm sorry about that.
Okay, let me open your presentation.
Sure.
I think I can do right now. Okay, everybody see the screen? Hello, Nasir?
Yes, sir, it's visible now.
Nasir, you can see?
Yes, I can see.
Okay, sorry if I can delay in changing the slides, but I will try my best.
Okay, no, that's not a problem. Hey, Doctor, can you stop sharing and I think I can, they are coming out as a little bit fuzzy, but that's fine with me. Okay.
Okay, so I will stop sharing.
Done. Open PowerPoint. Do you guys see it now?
I cannot, but I don't know about others.
No, sir, it's not visible. It's a blank screen.
It's a blank screen, yeah. Now it's here. Yeah, go back. Yeah, it was come before.
Okay, hold on. Yeah. I know what is going on. Give me just 1 second. Bear with me for a second. Junaid, go ahead and you share it. I don't know what's going on at my end. Sorry about that.
Okay.
Sorry about it.
Okay, so now everybody can see?
Yep, I can see that. Assalamu alaikum, everyone. First of all, extremely apologetic about this technical glitch. We are old people, and at least I'm an old person, so I don't know exactly how these things work. My name is Nasir Rashid. As Farhan mentioned, I am working at Central Siena Hospital, and definitely PPHN is one of my interests. Junaid, next slide, please. So before we go to the topic of pulmonary hypertension, PPHN, what I want you guys to understand is that let's go back in time 20 years ago and understand what was the management protocol of PPHN at that time, and what was the incidence recorded based on one of the largest studies published back in 2000. And to this day, interestingly, that incidence pattern is still existent. Out of a total of 100 births, 2% of the infants develop some kind of respiratory failure. And this is a data based on Western studies. So I am not exactly sure what is the prevalence or incidence rate in other countries. But 2% of the total births in term infants develop some kind of respiratory failure. And out of those 2%, 10% end up developing PPHN. So the incidence of PPHN is fairly low in term infants in the Western world, but again, it's a very, very severe disease that we commonly encounter in our NICUs. It happens because of the failure of transition at birth, and we will talk about it in the subsequent slides. Most of these babies were admitted based on that study at about 12 hours after birth. And at that time, again, 20 years ago, the treatment protocol was hyperventilation, alkali infusion, sedation and paralysis, and inotropic support. I think the first study of nitric oxide was published in 1997, and it was still in the adaptive stage when this study came out. So as I mentioned, 4 of those way of managing PPHN was commonly the prevalent mode of treating PPHN. Next slide. Now, what we are going to do is that I'm going to present this case to you guys and grab a pencil and a paper. And as we go through the subsequent slides, write down how you want to manage this baby eventually. So this was this is a 26-year Xray of a 26 an infant that was born to a 26-year-old gravida 1 mom who is GPS positive. Membranes were ruptured for almost 16 hours. She received 4 doses of penicillin. Apgars were assigned as 8 at 1 minute and 8 at 5 minutes. And the infant was started on CPAP support and was requiring about 25% of oxygen by the time of 15 minutes of life. And the CAP gas revealed a pH of 722, 36 was the CO2 with a base deficit of -13. A CBC was done that revealed a white cell count of 14,600 with 47 sacs and 11 bands. So grab your paper and pencil, and once we are done with the presentation, after you learn what we are talking about, we are going to discuss the management of
Nasir,
this.
Nasir, one thing maybe I missed that you didn't tell us how premature or how mature this infant is.
Sorry about that. Term infant. This was a full term infant. I'm sorry about that. Next slide, please. Next slide. Yeah, so the fetal circulation, remember, this baby, we are going to discuss this as a case. This baby, while in utero, had reduced pulmonary blood flow because the placenta is not the organ of, lungs are not the organs of air exchange. Placenta is serving as an organ of air exchange, and about only 5 to 10% of the ventricular output is passing through the lungs when the baby is in the uterus, okay? And the pathways that are important to keep the pulmonary vascular resistance high and prevent the blood flow into the lung include the lungs are filled with amniotic fluid or the fetal fluid, and high level of endothelium, which is a powerful vasoconstrictor, leukotrienes and thromboxanes, and all these mediators are responsible for the increased pulmonary vascular resistance. There's a role of serotonin also, and we will talk about it in the subsequent slides, that how serotonin imbalance can lead to pulmonary hypertension. Next slide, please. So this is the schematic of how the fetal circulation will be. As we talked about it, the organ of air exchange is actually placenta, and mother is breathing for the baby. So the oxygenated blood from the placenta comes through the single umbilical vein and bypasses the liver through the ductus venosus and is pumped into the right side of the heart. Now, if you look at the picture, the blood and the color of the umbilical vein blood is bright red. That means this is oxygenated blood. And once it is in the right atrium, it is being pumped out. About 90 to 95% is pumped out into the left side of the heart, either through the foramen ovale or ductus arteriosus, because as we mentioned, there is increased pulmonary vascular pressure, which is preventing the blood from flowing into the lungs, secondary to endothelin, thromboxane A2, and leukotrienes. Next slide, please. Now, going back to the same slide, the same X-ray, this baby, when was born, took the first breath. Okay, so once he or she took the first breath, what happens is that the oxygen is replacing the fluid in the lungs. And what oxygen does, it causes rapid fall in the pulmonary vascular resistance. And we'll talk about in the subsequent slide. This subsequent breathing pattern and oxygen exchange at the alveolar level will lead to the pulmonary blood flow. The lungs keep getting distended with subsequent breath, and increased oxygen supply will lead to vasodilatation in the pulmonary vasculature and decrease in the carbon dioxide level. Now, the babies, when they are born in utero, they have either endothelin, thromboxane, and leukotriene levels being high, which are vasoconstrictors. But once they are born and they take the first breath, the endogenous or the nitric oxide that is part of the pulmonary vasculature of all of us is being produced, and it acts by the cyclic GMP pathway and leads to the pulmonary vasodilatation. There's another pathway that happens at the time of birth, which is called as the arachidonic acid prostacycline pathway. We'll talk about it in later detail. And that leads to the production of prostacycline, which will act by the cyclic AMP. Remember, nitric oxide is acting through the second messenger, which is cyclic GMP. Prostacycline is acting by the cyclic AMP pathway and leading to the pulmonary vasodilatation at birth. Next slide, please. Now, the factors that are responsible for transition at birth, and remember, transition means lowering of the pulmonary vascular pressure and increase in the pulmonary blood flow. So once the baby takes the breath and oxygen comes into the alveolar level, it leads to the nitric oxide production in the pulmonary endothelium through the oxygen. The more breaths the baby takes, it will lead to the alveolar expansion, which will also induce and increase the production of the enzyme endothelial nitric oxide synthase, which will help in production of the nitric oxide at the pulmonary endothelium level. And as I discussed in the previous slide, the nitric oxide acts by the cyclic GMP pathway, which is the second messenger. The other pathway at the time of birth that responsible for vasodilatation is the arachidonic acid prostacycline pathway, and this one acts through the cyclic AMP. The other factors that are responsible for decreased pulmonary vascular pressure are the natriuretic peptide. So far, this baby, the one that I showed you the X-ray, was born, was going through a fetal circulation in utero, and after birth goes through all those steps and leads to the decrease in the pulmonary vascular pressure. Next slide, please. Now, if this baby develops PPHN, and we will talk about it in the subsequent slide, it will be because of the decreased pulmonary blood flow, ventilation perfusion mismatch, And what it will do, it will cause differential cyanosis. Differential cyanosis means there will be difference between the pre and postductal oxygen saturation. There will be shunting happening at the foramen ovale and at the ductus arteriosus level. And there will be labile hypoxemia. This baby will become more hypoxic back and forth depending upon how you're ventilating. And the shunting will be happening both at the foramen ovale and at the ductus arteriosus level, and it is going to be right to left shunting, leading to the blood being siphoned away or pushed out from the pulmonary circulation and not getting oxygenated in the lungs. The extrapulmonary shunting is happening at the level of the heart, and these babies eventually develop unresponsive hypoxemia. Next slide, please. Now, this anatomical classification of PPHN is nothing just for us to understand, because if we understand this classification, we will be able to offer the best management for these babies. If we do not understand this and this classification, then we will not be sure while we are managing this baby is that how we can optimize the management or the treatment for these babies. The most commonest reason for PPHN is maladaptation, and it happens because of the passage of meconium in utero. And what happens is that once meconium is passed, and because the baby or the fetus is stressed in utero, it will lead to the pneumonitis. That pneumonitis will lead to surfactant inactivation, which will also cause decreased endothelial nitric oxide synthase expression. The same meconium-induced pneumonitis will lead to increased level of endothelin and thromboxanes. And remember, these are powerful vasoconstrictors, and these vasoconstrictors will lead to the increased pulmonary vascular pressure. And then over the top of this, in this meconium passage, these babies can also be septic. And if they are septic, they will have hypertension. So you have two things going on side by side. You have higher pulmonary vascular pressure because of the increased level of endothelin and thromboxanes. You have poor or inadequate ventilation because of the surfactant inactivation. You have inadequate vasodilatory response because of the decreased endothelial nitric oxide expression. And you will also have systemic hypertension because of the sepsis. Next slide, please. This is the second anatomical classification called as a maldevelopment. And this is all classic teaching back in the day, back from the data that was developed in, I think, in 60s and 70s. And we were using this classification to get more understanding about the pathophysiology. So maldevelopment is a condition where when you look at the X-ray, the lungs will be fully expanded. You will not see any pattern of aspiration. The lung parenchyma appears normal. Maldevelopment is usually idiopathic. It is associated with chronic, and I'm talking about means long-standing fetal hypoxemia. And these infants are usually growth retarded, chronically in utero hypoxic because of the placenta not developed properly. They also have hyperviscosity because of the increased red blood cell production, secondary to inadequate oxygenation in utero, and they are polycythemic. Luckily, we do not see these kind of babies commonly as reason for PPHN in the Western world. But again, we are talking about other parts of the world, so please educate me at the end of the lecture that how many of these kind of infants you have encountered in your own setup. Next slide, please. Now, the third one is called as the underdevelopment. And underdevelopment, obviously, as the term implies itself, it means the lungs are not well developed. And they are not well developed either because of the low amount of amniotic fluid or oligohydramnios. It can be because of a congenital diaphragmatic hernia or any kind of lung mass or chronic amniotic fluid leakage. And we are, in the current presentation today, we are not talking about these pulmonary pathologies. These are separate topics to be discussed separately, but yes, these conditions can also have concomitant PPHN. Next slide, please. Now, the reason, some of the points that I'm talking about in my slides are repetitive, but there is a reason. The more you get a concept of it, the more it will be much easier for you to come up with a management plan of the baby whose X-rays I showed you on my second slide. So what can cause pulmonary vascular vasoconstriction and remodeling? Perinatal asphyxia also. Ongoing sepsis, ongoing in utero hypoxia, ongoing acidosis, and increased level of endothelin and thromboxane A2. So remember that these babies can also have side by side, besides having PPHN, they can be asphyxiated, they can be septic, and they can be acidotic. Next slide, please. This is the one of a very good article that is published actually from a journal in India, and I'm just going to throw this slide for all of you, that when you are taking the history of the patient, make sure you look at all those predisposing factors that are mentioned on the left side. And we talked about the 3 anatomical classifications, and those can fit with these medical conditions. So birth asphyxia can lead to PPHN. Meconium aspiration, we all know that. The ongoing or concomitant sepsis and pneumonia can be a risk factor for PPHN. Pulmonary hyperplasia because of conditions like diaphragmatic hernia or chronic amniotic fluid leakage associated with prolonged or premature rupture of membranes. And pleural effusion can also lead to pulmonary hypertension. Ask the mother in the history about the drugs like use of NSAIDs. And remember, in countries like India and Pakistan, moms take these medications over the counter. So make sure when you're taking the history, ask these questions. And then there can be other concomitant factors associated with PPHN, which include an infant can have pulmonary hypertension along with RDS, hypothermia, hypoglycemia, and polycythemia. So when you are managing an infant with PPHN, don't just focus on the pulmonary pressure itself or oxygen level, also be paying attention to factors of temperature maintenance, glucose homeostasis, and how you are going to reduce the number of red blood cells that is causing hyperviscosity. Next slide, please. Now, this is again, as I said, I did it about like 15, 20 years ago. And this was on a LAMP model. And this study was done primarily on a LAMP model to look at the utility of prostacycline and milrinone in decreasing pulmonary vascular pressure. And the purpose of doing this study was that my mentor was also from India. And at that time, nitric oxide was not available in both countries. So we both thought, let's do something that we can use in countries where their nitric oxide is not available. So if you look at this slide from the top to bottom, you see the PGI2, which is prostacycline, produced by the cyclooxygenase pathway of the arachidonic acid metabolism. It goes from the vascular lumen into the vascular smooth muscle cell, where it will lead to the conversion of ATP into cyclic AMP. And remember, I told you guys that cyclic AMP is the second messenger for prostacycline, and cyclic GMP is the second messenger for nitric oxide. So when the prostacycline is produced, it leads to the increased level of cyclic AMP, which eventually leads to relaxation of the vascular smooth muscle. And then this cyclic AMP get degraded into AMP by an enzyme called as phosphodiesterase 3. And the phosphodiesterase 3 can be inhibited by milrinone. So if you understand these two concepts, when we'll go to the vasodilator therapy portion of our presentation, you will understand how to use those medications. Next slide, please. Now, so far, we talked about the anatomical classification. I've shown you that was that chart from an article published, and now you are in the delivery room. So now you have to make sure you have all the data available when you start managing this infant. Make sure you have a good obstetric history, how the pregnancy progressed in that particular woman. Was she taking any medications? What's the gestational age? As Junaid asked me very appropriately, that is it a term infant or a preterm infant? Is there any associated medical illnesses? Is mother taking any over-the-counter medications? how long the membranes were ruptured. I told you the baby's membranes were ruptured for about like 12 or 16 hours. Is there a history of infection? She was treated with penicillin. She was GPS positive. And what was the color of the amniotic fluid or the smell of the amniotic fluid? That is very important. So as we are progressing, we are also taking history notes and collecting data so that when we are done with this all treatment plan, then we can offer what we can do for this baby. Next slide, please. While in the delivery room, you have to make sure that you have assigned the pertinent APGAR scores. And if there's an evidence of asphyxia, make sure you are aware of it. Most of the time in Western world, when the babies are stressed in utero and have meconium stained amniotic fluid, usually either a neonatologist or a nurse practitioner is already in the delivery room. So APGARs are assigned by the neonatologist or the nurse practitioner. That person, whoever is in the delivery, will make sure that there is an optimal lung recruitment. So if the infant needs CPAP, you do the CPAP. If the infant needs PPV, you do the PPV. You titrate the oxygen that is being delivered to this infant in the same way as it is outlined in the NRP. You don't start with 100% oxygen. And if the diagnosis has to be made about the PPHN in an infant, there will be a pre and postductal PO2 difference of about greater than 20 millimeter of mercury, or the O2 SAT difference of greater than 5 to 10% between pre and postductal. If this baby needs intubation, go ahead and intubate, don't wait. And then try to complete all the tasks that we will be talking in the next subsequent slides within the first hour. Next slide, please. Besides attending the delivery room, doing the PPV, starting oxygen, and if the baby needs intubated, once you bring this infant to the NICU, you need to make diagnostics. You need to start treatment. You do a chest X-ray. You restrain the infant and make sure you have a central line in this baby. Confirm the line position. Draw appropriate labs like CBC, blood gas, electrolytes, culture. If you feel that this kid is septic, go ahead and start antibiotics. If the kid is hypovolemic, go ahead and start volume bolus or give volume bolus depending upon what you want to give based on the blood pressure recording. Alkali bolus, I do not do that. I don't know about the use of alkali in other parts of the world, and we can talk about it when we discuss this case in open forum. But before giving the alkali, make sure that your line is properly placed. If you are giving it through a UVC, it should be above the liver. It should not be in the liver or should not be below the liver. It should be above the liver. And then obviously order an echo. And I know that in several NICUs in Pakistan and India, the bedside echo is available and a lot of fellows are doing it. So if you have an echo available, go ahead and do the echo right away. And some neonatologists are good enough to actually find the position of umbilical venous catheter or umbilical arterial catheter on the echo. So if you can do that, go ahead and do that and confirm the position and the placement. Next slide, please. Now, as we talked about it in the previous slide, that these babies, we have to minimize the handling and the stimulation. So to minimize the stimulation and activity, we need to give them sedatives. I'm going to talk about two commonly used sedatives, and I'll give you my preference at the end. Morphine is commonly used as a loading dose of 0.05 to 0.1 milligram per kg based on the studies that were published in 80s and 90s. And it was done on a good number of infants, about 70. Morphine get metabolized into morphine 3 and morphine 6 glucouronide. And once you do a loading dose, you can do a continuous infusion of 6.2 to 40 microgram per kg per minute. And this data was collected on 12 infants. And it is a pretty good sedative and helps in minimizing the stimulation and the activity. Next slide, please. The data on fentanyl is available from 4 studies. All of those were published in the late 80s. And you guys will be surprised, it was on total of 34 patients, including few lambs. So not all 34 were actual in human infant, at least I think 4 were lamb models. And among the term infant, there was only one study done on the use of fentanyl. But now we use fentanyl as a very commonly used sedative in the NICUs. Next slide, please. Now, obviously, when you're either giving morphine or fentanyl, you're very concerned about the cardiorespiratory effect. And the two cardiorespiratory effects that are very important when you're giving opioids is that how that opioid is going to affect the pulmonary arterial pressure, because you definitely do not want that opioid to be causing increase in the pulmonary arterial pressure. You also want to be sure that it doesn't cause a severe systemic hypertension. And at the end, you also do not want that kid to become respiratory depressed. Now, the flip side is that when you use the opioids, by the time you're using opioids, most of these infants are already intubated. So I'm not terribly concerned about respiratory depression effect of either fentanyl or morphine on these infants. And as I mentioned, the cardiorespiratory effect was studied in about like 900 plus infants. And they found that the incidence of respiratory depression is about 13%. But again, these babies are usually intubated. So you are not worried about a severe apnea while managing PPHN. Next slide, please. Now, you sedated the infant, you restrained the infant, you put the line in, you have intubated, and you have started ventilation. Now you have to increase the systemic blood pressure. I'm hoping by this time, either a cardiologist is available and doing an echo and confirming the diagnosis of pulmonary hypertension, or a neonatal fellow is already using a bedside echo and measure and seeing that whether there is an evidence of pulmonary hypertension. So a lot of inotropes are available. I'm going to talk in the next few slides what are the options, and then people can pick what they want to use in this case. Dopamine is one of the commonly used. It's a central neurotransmitter. It is metabolized to norepinephrine. It acts by D1 and D2 receptors. And in PPHN model, in an infant with PPHN, if you have a bedside echo available, you actually want to see that by starting the dose of dopamine and whatever dose you start with, that your shunting is changed. If it is right to left, then it either becomes bidirectional or it becomes left to right. It should not stay right to left when you're starting dopamine. So you titrate the dose based on how the shunting is happening at the level of ductus arteriosus and foramen ovale. Next slide, please. By the way, in all my slides, anything that is being mentioned is was taken from a reference that is in the bottom of each slide. So again, if any one of you need a detailed article, I actually have all those articles, and I can either WhatsApp or send it to you as an email. Now, the other option of using any inotrope is norepinephrine, and actually lately more and more neonatologists are using norepinephrine as compared to dopamine, because what they've found is that when they measure the ratio of pulmonary to systemic arterial pressure, the ratio was decreased following norepinephrine infusion, which means that the pulmonary pressure dropped, but the systemic pressure rise. So actually it helps in improving the blood flow to the lungs. So that's why a lot of folks have started using norepinephrine based on the data that was published in 2008 from the study that is mentioned in the bottom of the slide. Next slide, please. Now, the third option is epinephrine. I do not use it. I know that some folks use epinephrine, and in this study published in 2006, some folks found that epinephrine and dopamine are comparable. And then again, depending upon which part of the world you are practicing and what kind of formulary you have available, between norepinephrine, epinephrine, and dopamine, you can pick what you want to start as an inotropic support. I can tell you there are certain hard facts that people practice for the rest of their lives. And if a NICU is using dopamine as a primary mode of inotropic support, they are not going to change to norepinephrine. And if somebody is using norepinephrine, they are not going to change to dopamine, and vice versa. The problem with epinephrine infusion is that it causes hyperglycemia and lactic acidosis. So something to be mindful if you're using epinephrine as an inotropic support for PPHN. Next slide, please. Now, another one is Dobutamine. I have not used Dobutamine since 2001. I know it's commonly used medication, and it is actually fairly decent medication because what it does is that it actually improves the left ventricular function. So if you have an associated left ventricular dysfunction in a PPHN infant, Dobutamine is a good drug, but it improves the left ventricular function, and it can be done from the dose of 5 microgram per kg per minute to as high as 20 microgram per kg per minute. And it does improve the pulmonary vascular resistance in these infants. Next slide, please. As I mentioned in my schematic slide, that the data that we collected on the LAMP model of PPHN, Milrinone can also be a very, very good alternative if used as a systemic or an IV medication as part of an adjuvant therapy for maintaining the systemic blood pressure. It acts as a drug that acts on the phosphodiesterase 3 inhibitor and actually increases the cyclic AMP level. And what it does is that it also improves the cardiac contractility. The data that I shared with you guys in my previous slide was on the intratracheal Milrinone, but they're based on the studies that now are being done in human models. It can be actually used as an IV medication. I do not have the dose at this point in time with me, but I can look up the reference for you if, for the IV dose. Next slide, please. Now, this is another new medication, and I don't know how many of you have experience in using it. We learned about it a few years ago, Vasopressin as an alternative for inotropic support, and it actually works. And the theory behind it is that it works through the V1 or the Vasopressin 1 receptor, which are primarily located in the systemic vasculature and not in the pulmonary vasculature. So what it does is that it increases the systemic vascular tone and increases the systemic blood pressure. It is usually not used as a first line of therapy. It is used as a rescue therapy for refractory pulmonary hypertension, where there is a systemic hypertension, despite using the INO and despite using other inotropic support. So as a last resort before a baby is being shipped out for ECMO, this can be used as a second line of management along with any inotropes that we discussed in the previous slides. Next slide, please. So hydrocortisone is also being promoted as a good supportive medication to increase the systemic blood pressure. And a lot of folks use it in almost in shock, any kind of shock. I do not use it when I'm suspecting that the kid is simultaneously septic, but there are data available where people have used in as a last resort before shipping the baby out again for ECMO. So what it does is that it increases the blood pressure, it increases the stroke volume, it decreases the heart rate, and it actually decreases the rate need for the several inotropes that can be used. So using either dopamine or norepinephrine along with vasopressin, and if your systemic blood pressures are still not where you want those to be, then you can use hydrocortisone. But again, please make sure that there is no concomitant infection or sepsis in that particular infant. Next slide, please. Again, the original way of managing PPHN, where you want to maintain the pH and the acid-base balance at a certain level, has changed in the last 20 years. We do not do hyperventilation. We do not do alkaline infusion. It used to be done as a primary mode of therapy back in 2000, now no more commonly. Because what happens is that when you do the hyperventilation, you decrease the CO2 level to the point that actually decrease the cerebral perfusion, and it can lead to sensory neural deafness. So what they do now is that you can avoid the acidosis in these babies by giving volume boluses, and if needed, maybe a small dose of alkali as a bolus, but not as a continuous infusion, and try to maintain the pH between 7.25 to 7.35. Next slide, please. So where the SATs should be maintained in a PPH in infant, it should be maintained in the level between 90 to 97%. And the PaO2 on the arterial blood gases should be targeted between 55 to 80. Try not to over-oxygenate these babies, because when these infants are exposed to a higher amount of oxygen based on the data from the newborn lambs, the reactive oxygen species are generated, and those reactive oxygen species can decrease the level of endothelial nitric oxide synthase, decrease the production of nitric oxide within the pulmonary endothelium, increase the phosphodiesterase 5 activity, so the cyclic GMP is degraded easily. And what it does is that it actually potentiates the pulmonary vasoconstriction. So oxygen in a optimal dose is very good, but giving it in a higher number is not going to help, because it will generate reactive oxygen species. Next slide, please. Now, obviously, this the infant with PPHN should be ventilated, and there are various modes of ventilation available. I am not talking about conventional ventilation at this point in time, because I think a lot of data has already been published that talks about the value of actually high frequency ventilation, and probably one of the best use of high frequency ventilation is in PPHN. And when it is combined along with INO, there is a great improvement in the oxygenation. And if the infant has a concomitant RDS, that will benefit from the high frequency ventilation. So a lot of folks in the United States, I do not know many, probably just a few, they will go directly to a high frequency ventilation when managing a PPHN infant, instead of trying conventional ventilation and then move to high frequency. Next slide, please. When you do the ventilation, and whether you do the conventional or high frequency, and I know there are parts of the world where high frequency ventilation may not be available. If you're doing a conventional ventilation, make sure you do it a gentle one, where the PEEP should not be too high. Your PIP should be low to target PO2 of 55 to 80 in the arterial gas. A little bit of permissive hypercapnia is okay, and CO2 of 35 to 50 is reasonable. And just try to maintain the optimal lung recruitment and expansion, and avoid the barotrauma if you're using a conventional ventilation. And that is where the oscillator is very helpful, because it causes less barotrauma as compared to conventional ventilator. Next slide, please. Is there a role of surfactant in PPHN? The best way to calculate whether the infant will need Curosurf or any other kind of surfactant is to calculate the OI. And that is important, because what it does is that it gives you a number that will give you an idea how the infant is progressing. As you either do surfactant or start nitric oxide or start inotropic support, your oxygenation index will fluctuate, and a typical cutoff for sending these infants to center for ECMO treatment is usually 40. But giving surfactant, if the OI is between 15 to 25, it's better to go ahead and give surfactant to these infants. Next slide, please. Now, inhaled nitric oxide, I think it's probably one of the most talked about medication, and probably one of the greatest discovery in neonatal medication in late 90s. Trials were done in 1997, and then several trials were published between 97 and 2000. And then we have a Cochrane review from 2000, and almost every level 3 NICU is expected to have inhaled nitric oxide available in their unit. Usually, if there is an echocardiographic echo evidence of PPHN, which means right to left shunting with increasing OI greater than 25, despite giving Curosurf and despite optimally ventilating these infants, it's better to go ahead and start the nitric oxide, and it actually reduced the need for ECMO. Next slide, please. And as I mentioned, if the OI is constantly increasing, despite doing all the measures that we talked about so far, then it's time to think about sending these kids to ECMO if there's an option available for ECMO. Next slide, please. Now, I'm going to talk very briefly about the other vasodilators besides nitric oxide. Prostacycline is very well established, whether it's given as an intratracheal or IV form. It definitely reduces the pulmonary vascular pressure. There are analogs of prostacycline called as Vasopressin sodium, iloprost that are available that can be used. I have zero experience on those because we do have nitric oxide available. But again, in parts of the world where nitric oxide is not available, the options are prostacycline, Vasopressin, and iloprost. Next slide, please. Sildenafil is always available in any part of the world where there are meds. So if you do not have any vasodilator available, think about using sildenafil. The oral dose is 1 to 3 milligram per kg every 6 hours. There's a systemic dose, and the systemic dose is shown to be very effective in improving oxygenation in patients with PPHN. The dose is mentioned of 0.4 milligram of loading dose, followed by a maintenance dose of 0.07 milligram per kg per hour. Next slide, please. Milrinone is also an option as a pulmonary vasodilator. We talked about it as an intratracheal, but it can be used as a systemic loading dose, followed by a maintenance dose. Loading dose of 50 microgram per kg, followed by a 0.3 to 1 microgram per kg per hour of maintenance dose. And it is usually very effective if you're dealing with a PPHN along with severe left ventricular dysfunction. So if there is an evidence of left ventricular dysfunction, using it, this medication is very helpful in lowering the pulmonary pressures. Next slide, please. Byzantine is another medication that is available. And there was a study published in 4 infants from Thailand, and that shows the beneficial effect of this medication as a pulmonary vasodilator. Next slide, please. Skip this one, please. Next slide. So now we are back to our patients, and the same patient that I showed you the X-ray. So now this patient is almost 4 hours old, and the X-ray on the left is the X-ray that the baby has. If you can pay attention, you might be able to see that the lungs have changed. There's low lung volume. There's definitely more haziness on both sides of the lung fields. And on the right side of the X-ray, you can see some lines have been placed. You cannot see the ET tube, but I can tell you on this second X-ray, I cut it inappropriately in a short, but the ET tube is in place. So now this is an hour-old infant with both umbilical, arterial, and a venous line, and intubated, and is on vent support. So I'm open for discussion and interactive discussion on how any volunteer who want to come out and say how they will manage this infant based on what you have learned so far. Thank you very much. Jeanette, go back to the X-ray slide. This is the final wrap-up slide. I just want to see how people have come up with their management plan. And if any one of you have not done it, that's fine. Don't worry about it. I can tell you how I manage this infant. If somebody wants to volunteer and talk about how they will manage, that's fine. Otherwise, I can show you in my next 2 slides how I manage this infant based on what I have just discussed with all of you so far. And I'm open for questions.
Yeah, so I must say, anybody from the audience, please raise your hand. I think Dr. Mubarak Naqvi raised hand. Yes, Dr. Naqvi, go ahead.
Assalamu alaikum, and Dr. Nasir, excellent presentation. You revised, did it in a very nice way with pathophysiological background and clinical background. since I always like history and neonatology, and Dr. Junaid has also exchanged some ideas on. So this condition was first observed clinically by Dr. Medina Desmond in the 60s. And she noticed that the babies with the persistent pulmonary hypertension, at that time there were no echoes. It was a differential cyanosis. The lower extremity was cyanotic and the upper was pink. So that was the first establishment. It was published in clinical pediatric clinics of North America. And she established that transitional period of babies. And that's what it came out. And then the other thing, Dr. Desmond also noticed that the pulsation of the umbilical cord lasted longer, and she thought that it was due to increased pulmonary pressure. The second thing I may want to add on is meconium aspiration, as you elegantly presented the damage, and also it is inactivation of surfactant, plus also they say that the impact of pancreatic enzymes present in the stool will also cause damage to the lung. So I just wanted to bring that up. And the hyperventilation was established, I think, in Philadelphia, and there was a critical PCO2 number which was less than 30. And as you mentioned, it caused brain injury, hypoxic injury, and there were a lot of deafness in the long-term follow-up of these babies. So that's why it was abandoned a long time ago. I think it was Dr. Fox who introduced that. But that's all I have to say. But excellent presentation. Few things for clinical management also, especially for residents and so on, positioning of the baby. And we always learned, I don't know if they do that in all centers, immediately after assessment, put the baby prone, and that will increase your oxygenation, and you may not have to use very high pressures. So that's what, when I work in the nursery, I always advise them to keep the baby prone. And if the oxygenation is not improving, then I ask them, is the baby prone? And yes, Dr. Naqvi, the baby is prone, but the oxygenation is. So this is one of the management to keep the baby prone in initial management. And that's all I have to say. This is just a little bit of history, but thank you so much for giving this time.
Thank you, Dr. Naqvi. Dr. Sajjad, go ahead.
Yeah, thank you. Thank you very much, Dr. Nasir Rashid, for excellent and elaborate presentation.
Thank you.
I just wanted to raise 2 points. As you said in the very beginning, that you are interested to find out something other than nitric oxide, which can meet the needs of the countries where nitric oxide is not available. And one thing which is coming is the sildenafil. But the other thing which you mentioned was the alkalinization and hyperventilation. And that is a method actually we used when I was doing my fellowship in Toronto. And at that time, the nitric oxide was being used. But those babies who were, I know, non-responsive, they were being tried on the hyperventilation and alkalinization. And I think still that is a method which can be used in countries where nitric oxide is not available. And it really works. And whenever we were successful in raising the pH to more than 7.45, or just to 7.5, the pulmonary hypertension will spontaneously resolve. And we used to achieve it by hyperventilation, keeping the PCO2 between 25 and 30, and by giving a continuous infusion of sodium bicarbonate and maintaining the pH at a certain level. And it actually is a very useful method. So I just wanted to raise this point because many of your audience would not have the facility to use nitric oxide. Thank you very much.
Dr. Sajjad, I beg to refer strongly on this point. This is very harmful techniques, and it will give the baby a very severe side effect, from anything to from brain damage to the hearing loss to the decreased venous return output, decreased cerebral blood flow, and it is totally not recommended right now. This is, if you want to, I will send you the this thing, because there is no prospective randomized trial to date on these techniques. So in 2016, it is published there. Now, if the INO is not available, then there are many other ways we can do the, we can deal with that. So keep the pH above 7.45. The PCO2, especially lower 20 to 30, is a very, very harmful technique. I think to me, with all due respect, Sajjad bhai, we shouldn't recommend this. If Dr. Haq or Dr. any other senior has comment on that, or Nasir, you yourself, you can comment on that.
Yeah, sorry, can I just say one thing, Junaid?
Yes, sir.
I don't think this is a complete no-no to this hyperventilation and alkalinization. It is still mentioned in the books as well, and people are still practicing it. Actually, it is a controlled hyperventilation. What you are mentioning about the low CO2 is when it goes uncontrolled. When you keep it between 25 and 35, and you're in very good control of it, the hearing loss happens when the PCO2 falls below 25 and particularly below 20. Okay. But one has to be very cautious about it. Okay, this is, of course, this has got side effects.
Yeah,
alkalinization as well as the low PCO2. Sure. But there are some safe ranges in which you have to operate. And the idea is not to lower the CO2. Lower the CO2 is one mechanism. The other parallel mechanism is alkalinization. The idea is to increase the pH. And actually, it is the pH which opens the pulmonary blood vessels, not the low CO2. So we're not using low CO2 to open the pulmonary blood vessels. It is the alkaline pH more than 7.45, which actually spontaneously opens the pulmonary blood vessels. And we have seen a dramatic response to this when I was working in Canada during my fellowship. Thank you. Okay. Any comments are welcome.
Sure.
So, Dr. Junaid and Dr. Sajjad, thank you very much, and Dr. Naqvi. Just 2 points I just want to mention is that yes, I agree and a little bit disagree about the alkalinization and the pH. It was used very commonly back in those days in 90s and even early 2000s. But I think finding a right number is challenging, and obviously with the availability of nitric oxide in my part of the world, we try to keep it between 7.35 to 4.75, 7.25 to 7.35. Even 7.4 is fine, but we don't go above 7.45. We don't go below 7.25. And the problem is that if we manage this infant very well and everything turns out okay, and we send this infant home and 2 years later he has a deafness, trust me, I'll be sued if I was practicing any pH less than 7.4, above 7.4, or a CO2 of less than 30. So I'm just giving you that a little bit of perspective from my end. Thank you.
Yeah. Nasir, I have 2-3 questions.
Sure.
Just if you elaborate for all the audience. First thing is the dopamine. You are still using the dopamine because now the recommendations are against the routine use of dopamine.
Dopamine, yes.
So yes, we are still using dopamine, and the reason being that 2 of our attendings were trained in USCLA with Esteban Siri, and if I did not share the data of Esteban, but Esteban still talks about dopamine as one of the frontline and best medication when it comes to for inotropic support. And he has published studies even on infants with pulmonary hypertension and everything. So for us, I think we use dopamine primarily because it's we have used it for a long time. B, again, there's some data that supports it. I learned a lot during making this presentation that maybe in our next division meetings, I'll stir up the pot and discuss that maybe we should start considering our first line approach and maybe switch to norepinephrine, because the data, when I looked at it, it is highly supportive. And I know Dr. Satyan spoke about it in his presentation that was shared on the and on the forum. And maybe you guys know or not know, Satyan and I worked together for 3-4 years in Buffalo before I moved on to Washington State and he moved on to California. So I'm sure if I'll give him a call, he'll give me a hard time saying why you're still using dopamine. So yes, dopamine. We probably may walk away from dopamine in a few years, but as of now, we are still using dopamine. Sorry, Pat.
Yeah. So the thing is that even the Satyan is also actually he's the one who published a lot about and not to use. But anyway, the other thing you mentioned about epinephrine and norepinephrine. So you are in favor of norepinephrine more than epinephrine. Is there any particular reason about that?
So the problem with that, our epinephrine A is causing a little bit more of what do you call as the metabolic effects. Remember, I talked about hyperglycemia and lactic acidosis, and primarily it is because it causes severe vasoconstriction. So if we have a baby who is like PPHN and is now besides hypertensive is also bradycardic, then we use epinephrine as a last resort while we are already using either dopamine and vasopressin. So if an infant is already started on dopamine and we maxed out on the dose of 20, and then we use vasopressin and we are starting maxing out on the dose of vasopressin, then we use epinephrine, but not epinephrine as first line of treatment.
Okay. So that's about from my side.
One thing, can I say something?
Yes.
As Dr. Nasir mentioned, permissible hypercarbia is beneficial for tissue oxygenation and so on. So that's why I think now I would support the permissive hypercarbia and keeping the PCO2 a little bit on the higher side because it helps in tissue oxygenation.
Yeah, that's the thing. So that's very good, Dr. Naqvi. At least somebody is in favor of with me. Okay.
I know.
Mohsen,
everybody
Mohsen,
has their own thoughts and thinking, but these should just.
I just try to do this like a more in a way that what is the evidence right now. So first Mohsen and then Rafia. Go ahead. Mohsen Ali or Rafia, whoever can go, just unmute yourself and ask the question. Sajjad bhai, you want to say? Yeah, walaikum assalam. Yeah, go ahead.
A very nice presentation. So my question is the availability of the epinephrine is available in our part. So we have to go for the epinephrine and not for the norepinephrine. So what should be the monitoring criteria for the babies who require epinephrine? So should we go for the regular monitoring of the serum lactic acid and the BSR?
I think couple of things. A, when you are starting epinephrine, make sure first of all, make sure your UVC is above the liver, because God forbid if the UVC is in the liver or below the liver, that liver will be completely necrosed. So that's the first thing you want to make sure. The second thing is that the moment you start epinephrine, you will see a change in the perfusion and how the cap refill is. And that can serve as a sort of a Puer's-Main way of detecting lactic acidosis. I can see a baby turning from pink to start turning a little bit gray and ashen. And fortunately, in our setup, whenever we do the blood gas, lactic acid runs as a part of blood gas and on the bedside. So we monitor lactic acid very closely when we are doing epinephrine.
Can I add something, Nasir, on this?
Sure.
Okay, so I actually there's a mode of action. There's a receptor. So Rafia, norepinephrine working on alpha 1 and alpha 2. Epinephrine is working on beta 1, alpha 1, and beta 2. Beta 2 receptor can cause the hyperglycemia and lactic acidosis, but the beta 1 receptors is a little bit more beneficial because it has chronotropy, ionotropy, and dromotropy effects, which increase the stroke volume and the heart rate and the left ventricular function. So if you have epinephrine, you can use it, and as Nasir said, you can monitor the glucose and lactic acid. There is no thing, and especially if I can send you, because the latest what you call the guidelines by Dr. Kessler and Dr. Satyan, that when the normal blood pressure and the cardiac function is normal, what you can do when the normal blood pressure and abnormal cardiac function, then milrinone, dobutamine, and epinephrine is the drug of choice. If the low blood pressure and the cardiac function is normal, then dopamine, norepinephrine, and vasopressin is the drug of the choice. But the dopamine is a big question mark because it can increase the chances of the right heart failure as soon as it does. So if you have epinephrine, I think you monitor it and you can go ahead with that. Mohsen, you have a question? Please unmute yourself.
Assalamualaikum. This was a nice presentation. I want to ask about Bosenton. In the end, it is a newer drug. What is its availability in Pakistan, and any trial in newborn babies in Pakistan?
Anybody from the home country? Vikram, can you answer? Is Bosenton is available there?
Yes, sir. Bosenton is available in Karachi, and there is no any study done over here for the results. So, but it is available and it is used in some hospitals for PPHN.
Okay.
It's again available in Lahore as well.
Okay.
That's good.
So, Mohsen, you get your answer?
Thank you.
Okay.
We can use it in do and die situation.
Do and die situation. Okay. So, what is do and die situation, Vikram, for you?
Well, in the end, when we have nothing and we utilize all options, baby is not responding, then we use it.
Okay. Okay. I got your point. Okay. So, Nasir, because we are.
Can I just ask one thing?
Sure, Sajjad, sure.
Yes, sorry. Yeah, actually, the point I wanted to raise was exactly what you have said from the Satyan's article about the use of inotropes in various situations.
Yes, exactly.
And I'm not very sure about the use of noradrenaline so frequently as being perceived. So I think it will be very nice of you if you can share this article in the group. This is one thing. The second thing is, I think we have to involve the cardiologist in the management of PPHN. And it is usually the echo-guided management, if we have that facility. If we are lucky enough, and somebody should be helping us. Sometimes we do twice a day echo in these babies. Exactly. Only to see the cardiac function and see what is the right inotrope to use and what is not the right inotrope to use. And we can change accordingly. That will be the best. It's a giant multidisciplinary management between neonatologists and the cardiologists.
That's why they are doing this, that if the cardiac function is normal, if the cardiac function is not normal. So that's exactly what they are suggesting, that if you have monitoring of the cardiac function, then it's perfectly can be done. The one more thing about Nasir, that as we are talking in the places where the iron are not available, you didn't mention about magnesium sulfate. And I remember that there are two recent articles from low-income countries, from Bangladesh and from Jordan, that they are using it and they are very much happy about that. Do you have any comment on that?
Thank you, Dr. Junaid, for pointing out about the magnesium sulfate. So you may not believe it. Before coming here, my dissertation for my FCPS was on the use of magnesium sulfate in PPHN. Mm-hmm. But what I learned when we always look at things from the pathophysiology perspective, and there's no article that mentions about the pathway where magnesium sulfate is acting. At least I could not find one. But yes, there are several studies published from Switzerland, from Saudi Arabia, from Bangladesh, from Pakistan, where either the INO is not readily available. they use magnesium sulfate. And again, in a country like India and Pakistan, I think it's a great medication to use. Unfortunately, I do not remember the dose at this point in time. I think Dr. Sajjad knows about it.
Yeah, and
Yeah,
but
I
there
think
are
we have used it
yes.
for a long time, particularly in INO resistant cases. It's very high dose, but it does work.
Yes.
And it's very good choice in low and middle income countries.
And it's
So
also
Junaid,
neuroprotective.
Yeah.
Yes, it's effective, yes.
Junaid, let me ask you this.
Yes.
You have INO available in your center.
Yes.
And when you have thrown everything from the kitchen sink, like you started your first inotrope, whether norepinephrine or dopamine or whatever, and then you started second inotrope, you started your steroid, and you optimized the ventilation, and you started nitric. And if you do not have an option for ECMO, then do you use magnesium in those babies, or do you hyperventilate them? If you have to pick between the two, which one would you do?
No, we don't use magnesium sulfate. The last resort, we use a hydrocortisone. That's the last thing to bring up the blood pressure and try to work it out on the pulmonary pressure with this thing. And you discuss about, and then we use the Milrinone in the high dose. So this is one of the way, if nothing works, but we hardly reach at this point because we have ECMO available here also, and also in Rochester, May also. It's not a big issue to send for the ECMO, but this is the two things. We are not hyperventilate the kid. We don't give the magnesium sulfate. We give the maximum dose of the Milrinone, and then and start the baby on hydrocortisone. And as soon as the systemic blood pressure comes up, we notice that the saturation goes up, and then we try to see that how the baby is going, and if it is stable enough to shift to the ECMO.
Okay.
So another question for the audience, and Junaid can go, or Dr. Sajjad can answer that if just for my better understanding.
Sure.
Is that when everything is done, and including nitric and everything, if the kid is more than 12 hours old and still is on more than 60% of oxygen, do any one of you give a second dose of Curacil or surfactant? There's definitely a role for first dose, but how many of you use a repeat dose of surfactant as part of throwing the kitchen sink on these infants?
We don't give second dose of surfactant.
No, we don't give either. Surfactant has nothing to do per se with the pulmonary hypertension. Unless surfactant deficiency itself is a problem, otherwise it has no role. And similarly, when, so let me answer to Dr. Junaid as well, they're using hydrocortisone, but hydrocortisone per se has nothing to do with the pulmonary vascular resistance. It's only to raise the systemic blood pressure. So it's one of those exactly where we want to balance the shunt.
So see, the mode of action of the glucocorticoids, which is the hydroxide, that it have the vasodilatory effect all over the body. It is the cyclic GMP, and the cyclic MP is acting on the both. So if you it decrease the PD5 activity to cyclic GMP increase, which promote the vasodilation. So I think it has a little effect on the pulmonary circulation, but the other effect which we are utilizing more is to raise the systemic blood pressure to reach the level that the oxygen saturation goes up, and then and we notice this when the systemic blood pressure become a little bit higher, then the saturation goes up, and the pulmonary hypertension is a little bit, it get better. So I think this is the work.
The second part is the more important thing, to raise the systemic blood pressure so that you can reverse or at least balance the shunt between the right and the left side.
But if you see the I will send you the article because I don't remember the reference now, and they have that it normalized the prostaglandin E5 activity, and increase the cyclic GMP, which promote the vasodilation in the pulmonary circulation. So this is, as Nasir said, that this is the last resort. I mean, when everything is, before go to ECMO, of course, we are not doing, for every kid, but this is the thing. Naveed, you have question?
Yes.
Sorry. Khalid, Dr. Sir, yeah, go ahead. Sorry, Naveed.
Let Naveed go first. Let Naveed go first. No problem.
No, sir, you go ahead.
Sir, go ahead.
Wonderful discussion among the seniors. But for people who have neurodegenerative stage like myself, please, can you simplify what you would do in a case of PPHN? We've discussed from hyperventilation, alkalinization to many vasodilatation drugs and ventilatory methods. Well, that's all very good among the seniors, but we have a lot of younger colleagues and neurodegenerative people like me attending. So could either Nasir or yourself, Junaid, simplify it? Because this esoteric discussion can go on, but it doesn't help at the bedside.
You are very much right. You are very much right. So I have to simplify algorithm, and this is what we are doing. And I discussed in the last workshop also with Dr. Satyan also. So let's say we have the normal blood pressure and good cardiac function. We we try to maintain normal pH 7.35 to 7.4, and the PCO2. If we available nitric oxide, we start nitric oxide. If nitric oxide is not available, we start with the sildenafil. Normal blood pressure, but the cardiac function is not proper, then we start milrinone. If the low blood pressure with the good cardiac function, then we give the bolus and the slow bolus, and then we can start the norepinephrine, epinephrine, or the vasopressin. If the oxygen and normal pH and PCO2, then inhale nitric oxide if available. If nothing works, as I said, is the last resort is the hydrocortisone. So hydrocortisone plus milrinone before we preparing the baby to ECMO. So if the answer to the question that if the INO available, then you can start the INO. If INO not available, then you can start with the sildenafil. But as Dr. Sajjad said, that if you have the echo facility, see the cardiac function and decide the drug on the basis of that. This is what we called it, which we discussed in our last workshop also, that we have to have and I think many of in the centers in the Karachi, they have the facility of echo and they can do accordingly. But if you have a nitric oxide, then again, this is the famous algorithm by Dr. Kessler, which is the 20-20 rule. They start with the 20 parts per minute, and it has to increase the oxygenation by 20 mmHg. This is called the response. If not responding, then you have to go into the other pathway. But if the baby responded, then you start weaning it, and within 60 minutes or so, you can start weaning. But anyway, I will share both algorithm. These are the simplest way that you can do it according to this thing. Then if you don't have anything, no INO, no sildenafil, then of course, whatever the medicines which Nasir just discussed, Bosentan, milrinone, I think these medicine now available, you can start with. And if not, then of course, magnesium sulfate will help in this situation. This is my simplest thing, but it is, of course, thing.
Thank you, Junaid. Thank you, Junaid.
Hello, so Dr. Haq, just one point I want to add. Junaid has already elaborated very well. The last two slides actually have the list of things that can be done in a setup. So if you open up the presentation, the last two slides are mention everything in that order. And again, Junaid can also share the algorithm for folks who are working in the
we can do that. That if I think you can share your presentation on the academic neonatology, and then we can share the algorithms for everybody. Okay, so
Thank you. Thank you.
In the,
yes, thank you, sir.
Can I say something quickly?
Yeah, sure.
Dr. Khalid, old is gold. We are full of gold and knowledge, and I think, but we should impart it to our younger generation, neonatologist students. And I think most important is the nursing education. We have to improve the nursing education. And as Nasir mentioned, we should teach them pathophysiology of the disease so that they know what to do and when not to do and what not to do.
Yeah, these are the supportive.
But please do it simply. But please do it simply for people like me. People do it simply.
Simple. And then the other thing is there had been studies from I think Saudi Arabia or Middle East about the use of hydrocortisone in the management of babies with meconium aspiration syndrome. As you know, it is an inflammatory process. To suppress that, they had used that and they had good results, but I don't have much experience with that. And the other thing is from simple things like keeping the keeping the lights down, keeping the painful procedures lower, and also keeping the baby prone. I think these are simple things which we should teach our nurses and young students.
I think, this is all come into the supportive therapy, like temperature, nutritional, avoidance of stress and everything. Just one point I want to mention, that do not use too much narcotics because it causes systemic hypertension and it worsens the right to left shunt. So we have to be very careful in these situations. I think there is a time is 8:23. I mean 9:23 in Pakistan. So I think we can stop. If anybody have any questions, please put it in the.
Naveed has something to ask. Naveed, go ahead.
Naveed, yes. Oh, sorry,
Yeah.
I forgot. Naveed, sorry. You didn't.
Thank you so
sorry,
much, Nasir, for wonderful presentation. So my question is that you mentioned about the optimal PEEP. So the main idea is basically to teach here is to open the lungs, especially in the RDS. Without opening the lungs, I think starting INO is not beneficial. So we should not be like PEEP-phobic. So if the baby is having low lung volume, so PEEP of 7 or even 8 may be effective. And second question, remarks regarding Dr. Mubarak's Nakri about proning the baby. So I think he meant about when the lines are not there. When the USC and UVC is there, this is such a dangerous practice. So I don't know, maybe we can ask him whether he meant when the baby was simple on CPAP to prone him, or while the lines are there, because in the PPH and USC and UVCs are there, which are dangerous in babies when they are kept prone.
Can I think immediately without, before you put the lines in, put the baby prone, it's the comfort zone of nurses and doctors working in a particular unit to keep the baby prone or not prone after the central lines are placed in. Where I worked before in our center, we had babies are not improving and we did put them prone and kept them prone, even with central line by vigilant checking of by nurses and other people around them. So it depends upon your comfort zone and where you work and the comfort zone of people working around you. This was initially prone. I don't know if you know, because I worked and learned a lot of history. Do you know who started the proning position and where it was to improve the oxygenation?
I think, Dr. Nafi, we will get a history lecture from you. Just because of the time constraint, I have to, because it is now it's more than.
It was started by observation for a medical student in one of the institutions in New Jersey, and she begged her attendings to let her do this simple study, prone versus supine position in babies who had respiratory distress. And initially they did not believe her, but then she proved them in a study. And I think this is a published study. Proning increases oxygenation. It pushes the diaphragm down and increases the lung volume. So that's
Yes,
exactly. I should keep quiet now.
No, it's okay. Thank you. So thank you, Nasir, a lot. Thanks a lot. And thank you all the seniors for fruitful discussion. If I think this is the topic which is you can continue and continue because of the versatility in this and in the management. But anyway, if anybody has anything, just put it in the main group, put it in the Facebook. All our senior, including Nasir, inshallah, try to answer all those questions. So Vikram and Faraz, back to you.
Thank you, Dr. Nasir.
Yeah.
Thank you.
Very nice presentation. And our next presentation is arrhythmias in neonates on coming Saturday. So join that on the same time. Thank you very much for participant.
Thank you, Nasir, very much. And you did an
you.
excellent presentation, and you went through a lot of things, which coming from basic to pathophysiology and so on, and basic management. I really thank you for that. Thank you.
Thank you.